because it's been a 1 year since the word pandemic came into our vocabularies. And I can't imagine anybody busier than someone with Chris's credentials. She graduated from Point Loma College over 35 years ago with a Bachelor of Science in Nursing, went to work at UCSD, where 3 months later she was promoted to the night shift supervisor and has been in hospital administration since. And she indicated this morning that she has worked at Rady Children's Hospital for 35 years. Chris, I counted the number of departments that report to you, and so far I've come up with 14. And that's a lot of departments to be overseeing in a very busy hospital, especially one with the prominence that Children's Hospital has in our community, because it's the only hospital that I think we know of that has a freezer that gets cold enough to be able to manage the temperature of the Pfizer vaccination. And clearly, Chris is the operations vice president of a children's hospital, but that hospital is as deeply involved in the coronavirus pandemic that has turned all of our lives upside down. I guess one of the few good things about it is that some of us are trying to learn, and it's taken some of us a year or so to manage Zoom. And I guess there are some benefits to that. But Chris, just let me turn this over to you. I do have questions that Charlotte, bless her heart, put together, and I think we'll save those until the end of Chris's presentation. And then if there's something that Chris hasn't addressed while she's speaking, then we'll go to the questions and hopefully have time for some questions also from the rest of us. But Chris?
Okay, well, thank you very much. I'm honored to be able to be speaking to you today. And it's been quite a year. For us, for Rady's, and in particular for my job, this actually all started in December of 2019. It was when we were first starting to hear about this novel virus in China, and our infection control committee, we did a big presentation, and we'd happened to have a tabletop drill in November on pandemic. So hospitals always plan for disasters, and then we had a couple hundred people at this tabletop. And in the pandemic, the scenario I wrote was one of the possible diagnoses of the novel virus was coronavirus. And we ended up doing it on avian flu, which is even scarier than coronavirus because it has a higher mortality rate. But nobody expected this coronavirus to be so efficient at transmission. In January of 2020, we set up our special infectious disease unit, which we had prepared for Ebola. And we're the assessment center for pediatrics in Southern California for Ebola. So we set up this special space with the environment set up for highly infectious diseases. We call it the Special Infectious Disease Unit. And I set up in January 2020, 30 beds on top of other isolations, knowing we wanted to make sure that we had a very contained area as you were learning about this virus. And we saw our first called PUI, person under investigation, on February 5th. When the expatriates were brought to Myanmar, any children that were potentially infectious during their quarantine were brought to Children's. And what was unique was that it was the parent and the child that had to come and they had to be quarantined. So we've been doing this for well over a year. And I know the recognition of the pandemic is a year, but we've been doing this for a little bit longer than that. So what I was going to do today is run through fairly high level, but a number of different topics, and including a lot about vaccine, and give you the latest information. And I'll hit highlights on those and then save time for questions, if that works okay. And I'll share my screen. And so can everybody see that?
Yes.
Okay, perfect. And I'll talk a little quickly, but feel free to flag me down if it's too quick. And I love these pictures, but this is the coronavirus. Different under when you look at the microscopic, and we're able to do this so well now in science. This actually is what the coronavirus looks like. So when you sample out of different cultures and different tissues. And I always want to talk, when I talk about COVID-19, where did it start? And we were finally able to identify that it was in the marketplace in Wuhan, China. The virus came from the bat. The bats were kept live in this, and it's a delicacy in this marketplace. And so they would be in the same place that there was other food products, meats and fish and vegetables. And through the contamination, this is where the initial virus was transmitted. If you think about our last pandemic, which was H1N1, that was what, 2009, that virus was a virus that was from a pig and a chicken that then transferred to a little boy in Mexico. And as the virus mutated and became transmissible to other species. So this one was bat to people. That one was, again, a swine flu, so swine, bird, and then to a person. And one of the things that I find fascinating about viruses is they do mutate. And they become very efficient in their transmission. And COVID-19 is certainly one of the most efficiently transmissible virus that we've ever experienced, which is why it spread so quickly. I just wanted to show we need herd immunity. There's a lot of discussion about where we are in that. And this is from the one of the journals that's out and talks about that we're by April, which I think is pretty unrealistic for us actually to have herd immunity. Since today I'm just in conversation with the health department. I asked for 9,500 doses of vaccine because that's how many people we have scheduled. And I'm getting 1,100 because there's such a vaccine shortage. And we'll talk a little bit about that. But we will get there, and I just don't think it's going to be in April. One of the things that I think is so important is to understand vaccine hesitancy. Those folks that are concerned about how quickly the vaccine was developed, and then, or in general, do not believe in vaccines. And as this slide just really simply shows, that between September and December, we've seen an improvement in the people being open to taking the vaccine. And for us at Rady's, our first wave of survey, we only had about a 60% of healthcare workers who said they would get vaccinated. And then there were 24% that said absolutely not. And there were, the rest were a little undecided. And I'm really proud to say right now we're at a vaccination rate greater than 75%. Nationally, it's around 64, in healthcare, 66. So we're getting there, and every day we have some of the vaccine hesitant folks getting the vaccine. Again, when you look at some of the information, men are more open to getting the vaccine, and those numbers continue to improve over women. And then one of our most vulnerable populations, the Black and Hispanic, are more vaccine hesitant than other populations. So it's really areas that we really want to go into and work with, because there's also a lot of comorbidities associated with these groups, and they're at high risk. They have some of the highest risk of mortality, both Hispanic and Black, related to COVID. So it's really important that they do get the vaccine. And the reasons people are hesitant is they're concerned about the side effects, and there are some. And what's really nice with the millions and millions of doses now that are out there compared to with just the studies, it's showing that there are very few severe side effects, very little anaphylaxis, lots of sore arms, lots of muscle aches. I don't know if you all experience that. Fatigue. I have a little trouble figuring out whether I'm tired because I'm tired or tired because of the vaccine. I'm not sure how people knew that, but those are the majority of the side effects, and it's up to about 35–40% of the folks. But it's nothing compared to the getting COVID-19, especially if you're in a vulnerable population. The other concern was the vaccine was developed too quickly. And a lot of that is that people don't understand that we did something very different in that the vaccine companies were actually paid in advance to do the development and do the manufacturing concurrently. So that usually what happens is that you do the development, you do the research, you do the testing, you get your approval, and then you develop your manufacturing piece. We did them concurrently. That is really, we didn't skip safety steps. What we did was we did steps alongside with the testing, and that made the difference in the ability to have vaccine available. So, but the safety factors were still attended to. And then a lot of people wanted to wait and see, and then you've got a whole group that just don't trust the government. That is a reason why. And there are a lot of reasons for that too. You can't. It seems like there's such a conflict in information that comes out. So the more we can get people out and talking about the facts, the better it is. And I think it's important that people know how effective the vaccine is. All three vaccines that are out there are over 95% effective at reducing the extent of the disease. So nobody is claiming that it prevents infection. The vaccines weren't designed to prevent infection. They were designed to prevent disease, which means you might have a mild case, you may have an asymptomatic case, but what you will do is not get very sick, and you won't get hospitalized, and you won't die. And all three vaccines have shown 95% efficacy related to those outcomes that we were looking for. And the good news is the most recent research is showing us that they're actually preventing disease and infection more than we actually thought. And that's new coming out, but that wasn't the initial goal. The initial goal was to prevent the deaths, especially in high-risk groups, and prevent the hospitalizations and their overwhelming of the healthcare organizations. And they've proven very effective. We do a town hall. We're on our 50th town hall. We've done one every week since March. We're a year out, a little over 50, I guess. And there are three of us. It's Dr. John Bradley, Dr. Alice Pong, who are both infectious disease physicians, nationally and internationally known, actually have been on the FDA committees. And then we have one other physician who actually sits on the FDA and CDC group approving vaccines. So we've been giving information every week, and we start out with what's new. And every time we get additional information and the science community comes out with something new, that's what we share with our staff and our physicians so that they have the most recent information. And you can see, and I'll send this slideshow to anybody who wants to look at any of these references, but we put dates on them to make sure you know how current they are. And I think, again, the important thing that the CDC is really talking about, the advantages, is that, and the recommendations that we really do vaccinate everybody. And with all the mutants and the variants, and we're going to talk a little bit about those that are showing up. And remember, I said viruses always change and they do mutate. If you think about HIV, there's 7 or 8 different strains of HIV. And H1N1 has changed, hepatitis B, hepatitis C, all of those have changed. And the coronavirus is no different than that. So it's something we expected. But and as you learn more and more about it, it's important to then know how effective the vaccines are. And it's looking like the majority of the vaccines are effective. The South African mutant, and we'll talk about that too, is a little less impacted or the vaccine's a little less effective against the South African strain, but it's very effective against the one that's from Britain. It's also showing us that the vaccine is preventing transmission. So if you are vaccinated and you do get an infection, and you may be asymptomatic, but it's also showing you're not transmitting it to other people. There's very little virus. And so it's, again, one of those things that's going to help eliminate this virus in the community.
Chris, excuse me for interrupting, but the slide before that one, you had something underlined in red and it said efficacy of Janssen. What is Janssen? I don't know.
Janssen is the new Johnson & Johnson vaccine. Johnson & Johnson purchased Janssen.
Okay.
So yes, and it's a little different than the Moderna and the Pfizer, one in how it's produced. But the other is in its effectiveness in against especially the mutants. But the thing that is the same for all of them, which is what we'll talk about, is the prevention of hospitalization and progressive disease is 95%, which is really, really good for a vaccine. Yeah. And nobody that has gotten the vaccine has died related to COVID. So it actually is, all three of them are preventing death, which is again the goal. So
thank you.
So you're welcome. I thanks for picking that up. So Johnson & Johnson, which is the Janssen vaccine, very confusing, is the newest one. And as you can see, it talks about being 75% effective with the in the US and 66% effective overall. And that is related to preventing infection, which isn't really the goal. But as you get more of the information, it's 85% on progressive disease. And actually even later, it's looking more like 95. Of interest, Johnson & Johnson's trials were done, a lot of them were in South America and Africa, and probably the mutants were already there. So its testing results in the research are showing a lower level of effectiveness, but it was probably because it was related to the mutants, and the mutants are a little bit less effective, less impacted by all three of the vaccines. But in particular, the Johnson & Johnson, and I think it's because there were more people with it. And that's what it appears by the research, because there was a lot of wondering why it seemed to be a little bit less, but the overall effectiveness is high. One of a couple of real advantages for this vaccine, and it being the newest one, just recently approved, is it's a single dose compared to the other two. As you know, Pfizer's 3 weeks apart and Moderna is 4 weeks apart. This is a single dose. It is an mRNA vaccine, which is very good. And the other thing that's very nice about it is just regular refrigeration. So we do the majority of our vaccines are Pfizer, because we do have the -70 freezer. It's kept our supply up, because a lot of people would prefer Moderna because you can use a regular freezer for that. It also is easier to set up to do the vaccine. So Moderna comes in a vial for 10 doses, you just draw up. Pfizer comes in a vial that you can get 6 doses out of, but you have to mix it in a very particular way. And then you draw up the doses, and they're only good for 6 hours. So the complexity for a clinic running these, the easiest is now the Janssen or Johnson & Johnson, then Moderna, and then the hardest to do is Pfizer. And so one of the things that we at Rady have done is, because we do have the freezers, said, we'll take any of the Pfizer and give the other ones any place else, because we have the systems down. But it does add to how challenging running these mass vaccination clinics are. So again, this is really simply just, I thought I'd just put this slide in here, talk about complications. You have any local symptoms, which was really the redness or sore arm, and pain at the site and swelling. All of 3 vaccines have pretty similar side effects. There's no one that stands out more than the others. You know, in different studies, someone might have more headaches, someone might have more fatigue, more muscle aches. Most of them have about the same, with a severe reaction, which is very, very low for anaphylaxis. So they're pretty comparable. And this is a slide by one of my infectious disease physicians put, and he said, essentially, we want everybody to know that all 3 vaccines are good. Dr. Bradley, Dr. Pong, and I would take any of them. We encourage you to go ahead and get these vaccines. We review all the data that come out, and we pour through it. And we have, fortunately, a really robust group of infectious disease physicians that do a lot of research. So we look for making sure that the questions we think are important are, does the vaccine prevent death? Absolutely, which is good. Does it prevent hospitalizations? All 3 do. Will it prevent symptoms of infection? Almost all the vaccinated folks that then test positive are almost all asymptomatic, or they have mild cold type symptoms. It's very little change from that. And then the viruses that are circulating, how do the vaccines work for them? All of them do well. The one that is harder, that is more not resistant, has less of an efficacy, that still prevents death and hospitalization, is the South African version. And again, we believe even the vaccines that are down the pipeline are going to be good for the mutated versions. Pfizer and Moderna are already reported they've modified their vaccine. So once you have the base vaccine and you have the base virus, and the virus starts to change, it's really easy to modify your vaccine. So if you think about the flu, every year we make a new flu vaccine based on the strains that are out there. It's a process, something very easy that we know how to do. We add 4 different strains. We hope we pick the right flu strains, and that's what they produce for the year. So this is what I believe our future will be for a couple of years, is probably needing boosters for this. The people haven't come out and announced it, but this is where we think we're going, related to the different strains that are out there and what is going to be most predominant in the community that you're out. And then all of just the other piece of vaccine production is anybody who's in the trials, they get followed for 2 years. So we have preliminary information from folks who started last year, but they will be followed for 2 full years. There's no recommended minimum interval between infection and vaccination. So I get a lot of questions of, I had COVID in January, when and should I get vaccinated? The answer is yes, you should get vaccinated. Originally, the recommendation was, within 2 weeks or after 2 weeks of recovery from your illness or your test, if you were asymptomatic, you should get vaccinated. But it actually looks like the natural immunity that you get from being sick and having COVID-19 is giving you protection between up to 6 months, but between that 3 and 5 month period of time. So right now, you can temporarily delay the vaccination if you want to. You don't have to. We just recommend that you don't get vaccinated while you're symptomatic. And most of our staff are getting vaccinated about a month after they've had COVID. And of interest, the natural immunity you get from being ill is augmented by the vaccine. The vaccine actually gives you a little bit stronger immune response than the actual illness, which is different from other viruses. There are some viruses that you get lifetime immunity to. but this isn't one of them. We're still early into this, but it looks like the immunity wanes. And that's why we believe we'll be getting boosters. The other question we get a lot is pregnancy. And in the beginning, in the trials, they didn't accept anybody who was pregnant, but of course things happened during a trial, and a lot of women got pregnant during their while they were in the research phase. Now they actually have great studies that are specifically for pregnancy. CDC, World Health Organization, and the organizations that focus on pregnant women highly recommend that you get vaccinated if you're pregnant, because the risk of illness is greater than the risk of a complication from the virus itself. And so it's nice that we now have all of the organizations on the same page, really recommending that pregnant women get vaccinated. This Be Safe reports. Be Safe is the, if you got your vaccine, you should have been able to get a Q code to be able to have on your phone and report any symptoms. And it's going straight to the CDC. So everybody who gets vaccinated here, we encourage them to use this and then report in. And what's really nice is somebody actually gets back to you every day and asks how you are and what you're doing. To the point where I've had people say, can I disenroll because I'm now doing fine? I had symptoms in the beginning, but I'm doing well. The biggest reactions, again, most people have are sore arm and a redness. There have been a number of cases that of large local reactions. So you can see all of these, mostly on the arms, but even on other extremities where it's big, red, looks very sore. And some of these reactions were coming up about 8 to 10 days after the vaccination. We have a team of actually dermatologists and allergists who are working with the CDC on this. And so they've got a very nice protocol on if you're one of those people that get this using, usually it's just antihistamines and topical steroids. Sometimes you need some prednisone to be able to make these reactions go down. But what was interesting, and this doesn't prevent you from getting a second vaccine. Still the belief is that with these local reactions, you are at less risk getting your second vaccine than running the risk of getting COVID. But of interest with this is out of these 12, those who got, all of them got second dose, and only 6 people had reactions at all. And 4 people had none, and then 2 had a very low reaction. So, and in most cases, you're thinking that the reactions are worse with the second dose, which is very well documented. But in this particular case, it didn't happen. And this is just what we use for folk when we screen people about when they're coming in to get vaccinated. And you ask the question, have you ever had a anaphylactic reaction, or do you have any allergies? We go through this algorithm that, again, our team helped the CDC develop. And if you ask the question, have you ever had any reaction to a vaccine component or to it, and they say no, you just keep going down the line of questions. The only time that it's recommended that you not get a vaccine at a regular vaccine clinic with COVID-19 is if you've got a known anaphylactic reaction to the components in the vaccine. And even then, the allergists are recommending you get the vaccine, but you get it in an allergy clinic where they're used to taking care of these reactions. And what they're doing is they're actually splitting the dose. They give half in one site and half in another site. And then post-vaccination, they give you a little Benadryl. And so our team has done extremely well with this. And everybody has, we've had nobody who's had any problem. The variants or the mutants, as they heard, weren't a surprise. As I said, viruses mutate. And I have immense respect for this virus in how efficient it is. And it's getting, the mutants are making it more efficient. The first mutant that was identified in Britain is, in the evaluation of it, they think it's 40 to 60% more efficient at transmitting. So when you have a room full of people and somebody has the virus, normally you would think 2 other people will get the virus with the way COVID-19 transfers. But now with this mutant that's found in Britain, originally found in Britain, you'd have 4 to 6 people. So that's quite an increase, and that's why they saw such a huge increase in the number of new cases in Britain. We haven't seen that happen, and I'm going to share you some of those numbers. As I said, the vaccine companies are already working on the second wave of the vaccine so that we can address these new strains. But again, all of them work well. Whenever we talk about, our staff really found this interesting when we talk about the spike protein. So the viruses are different than a lot of other, the vaccines are different than a lot of other vaccines we had. And they all use the spike protein, which is part of the virus, rather than either deactivating the virus and using a killed version of the virus to make the vaccine. This actually doesn't use the virus, but it uses the spike protein within the virus that can't cause disease. And this is what a spike protein looks like. I just always thought it was interesting that to be able to see what the scientists are working on. And then as you look at these arrows that are coming in, when what the mutants are doing are they're mutating on the spike protein in certain areas. So you can see this N501Y this is where the mutation is on this particular spike protein, and this is the mutation here. And they do actually connect to the other types of vaccines that we have, or other kind of mutants that we have. But it doesn't impact the entire spike protein, and how the spike protein responds and helps with immunity, which is why the vaccines continue to be effective. And I just love how science has evolved to be able to show us all of this. And if this had been even 20 years ago, we wouldn't have, or 50 years ago, we wouldn't have all of these images and the incredible science we have now to understand the transmission, how it's changing, and what we can do to put into measures we can put into stopping or making changes. So mutants, we're going to continue to have them. But right now we are tracking 6. We have the original one that was found in the UK. And this chart actually then talks about, like this one is, they think it's at least 40% more transmissible. There is suggestion that it's got a higher mortality rate, and it causes more disease. Some of that's a little hard to tell because they had such a huge spike so quickly in England, and whether it was just the volume or whether it really does cause worse disease. The and we're learning something about these mutants all the time. The South African is the one that is more challenging for all the vaccines, so the vaccines do work. We have one in California that we've been watching closely, and I'll give you some of those numbers as we move forward. I love the fact that Ohio has their own, and so I spoke to you in 3 months, we probably would have another 10 up here of just identified new variants. Of interest for us, and this is for this week, is the prevalence of the one from England, and California. Florida's got the most of them. California's high, and a couple of other states. And then this is the South African, which really hasn't taken hold here in California. Or much in the States right now, but we're watching them. One of the things that's an advantage for us in San Diego is we have UCSD, and we actually have the Rady Genomics Center and the Scripps Research Center that all do DNA sequencing. And it's the sequencing of the virus that tells us if it's mutated. So all of our positive tests we send to be to look for the mutants. And we've only had one that's been identified in pediatrics. But on this slide, this is a new slide that's on the last couple of weeks on the county site. That on the 3rd, we had 197 identified variants of all the tests that were being done. So it's still a very low number. It's not jumping up like England did at all. England just went straight up, and that's not happening here, in particularly in San Diego. Much more of a risk in Florida. And this slide I threw in here just to tell you that the scientists are really looking at how effective the vaccines are in neutralizing. And what you have is you have the regular virus on one side, and then you have the mutant virus on the other side. And the lines are showing the effectiveness of the vaccine. And bottom line is they're pretty effective, which is good. On vaccination, we're doing well, but I don't think we're going to be at that 70 or 80% by April, unless all of a sudden we get a lot more vaccine. The United States population vaccinated by this week on the 9th was 23.9%, but only 12% fully vaccinated. San Diego County is doing extremely well, and I'm very proud of the work that the county has done. We have 24% fully vaccinated and 13% 13% fully vaccinated and 24 who've at least gotten their first vaccine. And as you all know, we've been having trouble with our supply, and that the Petco Del Mar is closed, the mass vaccination site this weekend because they have no vaccine. And as I reported, I'm getting 1,100 doses, and I need 9,000 to vaccinate everybody that we have signed up. So this is a huge challenge. I talked to one of our health department folks this morning, and they really believe by the beginning of April, there'll be much more vaccine available. And I think this is where politics gets a little bit challenging for us, because on the, you hear everybody say we're going to be out of this by April, May. We're not. The other piece of it is remember, the vaccine is only good for the age 16 and up. And we have a whole lot of kids in this country who are still going to be vulnerable. Pfizer is doing their pediatric trials right now, and Moderna starts this month. Actually, we're going to be running a Moderna vaccination research site for kids starting this month. So we're pretty excited about that. And all of our staff and physicians are signing their kids up. So there's a lot of confidence in this vaccine. And the trials go all the way down to the age of 2 months. So it will be it'll be everywhere from 16 all the way down to 2 months. So this is the phases, and as really exciting, and they did actually change this yesterday. They didn't change the slide, but phase 1C opens this up to anybody with underlying medical conditions, originally with this limited list that is here. And yesterday they broadened that. And it's almost any underlying health condition, just simple hypertension, and no matter what your age, you're going to be able to get it. There is not a requirement for a letter from your physician, but we all have to change our consents so that you do an attestation to say that you actually have an underlying condition. There's a bit of a HIPAA issue. If we were to ask everybody, plus, it doesn't make any sense to try to, we want people to be honest and be in line where they need to be for the vaccination, and the clinics can't chase down whether people are being truthful or not. So anyway, very exciting that we will be able to do this. We send out messages to all of our patients who meet these chronic underlying conditions. And now I have no vaccine to vaccinate them. So it's kind of like the teachers, when we opened it, they opened it to the teachers, and there was such a limit in the beginning of vaccines. So we'll get there, but it's taking a little time. As you know, there are metrics that we're following that's set out by the state and then also impacted by the county. We are all currently, we in San Diego County are in purple, though all of these squares were dark purple for a long period of time, just started to go into the red and orange, which is great, which is our the percent positivity. And there are days that some of the tests we do when we run the testing that we're 1 to 2% positivity, which is so exciting because even in pediatrics, we were up to about 17, 18%. For the county, it was much higher than that. But so it's getting better. The one thing that has been added, which I think is a very good thing, is vaccine equity metric. So we may get into meeting all of the other criteria and getting into the red and showing improvement. But if our vaccination rates for our most vulnerable populations are not met, the state will not allow us to move to the next tier. So there's a real focus on diversity and equity for everybody to get this vaccine, which is really important. And that's what this is really talking about. This most vulnerable group, if we don't meet the minimum vaccination levels for them, we will continue to stay in a purple phase or red if that's where everybody is, and not being able to move to the next phase or next tier. And with each tier, this is when you can start eating inside restaurants, movie theaters can open, it impacts schools. So I like the fact that the state has tied vaccination levels to the other metrics to be able to move us so that we won't undergo another big wave. And I think all of those things are incredibly important. So the question of when we'll be unmasked and don't have to social distance, we need the herd immunity, which we talked about. And right now, there are a couple of states are saying you don't need masks, you do need masks. People can still transmit after vaccinating, though it's really, really low. And we're 12%, what is it, nationally of fully vaccinated. You need to be about 70%, 80%. And we know a lot of this from, chickenpox and measles and pertussis, which has been an outbreak in California for a really long time. So it's going to be a little while. Factors that influence all of this is how many are immunized, how contagious the virus is, what are the variants and mutants are doing, how effective and how long natural immunity from being sick and the vaccine are, how durable is the immunity, same thing. And if you do it in addition to masking and social distancing, if we do all of these things, we'll continue to move in the direction we need to. The CDC did a really nice, and it's such a nice website. If you ever don't have something to do and want to hop on www.cdc.gov and look at some of this, they put this out on Monday. And it's in response to some of the states that, like Texas, that are opening up and not masking, you don't have to social distance, to put a little structure there to say, here's really best practice, and to acknowledge we're moving in the right direction. Because if we don't acknowledge that, we're going to continue to have this disparity. So essentially what this is saying, green is vaccinated individuals. If you have people who are vaccinated and you have a small group, maybe another couple, and you're both vaccinated, you don't need to social distance and you don't need to wear a mask. You can go and have a regular evening. Always do hand hygiene, don't share food and all that other stuff. Same with if you have vaccinated folks and you have low risk. So if you're vaccinated, you can still transmit virus. It's not very likely. You wouldn't want to visit somebody who's very senior and not vaccinated, is essentially what this is saying. But if they're low risk, they're healthy individuals, they just aren't vaccinated, you also don't need to wear your mask. But in every other case, even if you're vaccinated, they If you have anybody who's high risk, they want you to continue to do all the safety things. And they are also saying if you are bringing more than a couple of people together, we continue to want with larger gatherings, and that's usually considered more than 6, to be doing all the practice. So the things that haven't changed are social distancing and really protecting our most vulnerable populations. It's just the thing that did change. I do like the fact they did this. It's your little hub or your little bubble of your immediate family members, to be able to be a little bit less stringent with those safety measures. So I talked a lot. I hope there was interest, and that I brought to you what you were asking for, and I'm fully open to take any questions you have.
Well, I understand that Charlotte has some questions prepared, but
I have them.
I may have to leave early, so I wanted to ask a question. When you were mentioning all the people, the adults that have been vaccinated and so forth, I heard that the homeless are going to be vaccinated, which is good because you see them around and they could carry. How about the undocumented immigrants, the undocumented people that live here? Are they going to be vaccinated? Because I know some people couldn't care less, but they do affect us too. So
yes, they're part of that group that are being targeted to make sure that they get vaccinated. We've been doing some outreach. We actually have a core, we call them our COVID-19 nurses, that are going into communities and reaching community leaders for some of these areas, which include some of the undocumented workers, and setting up appointments for them because they don't have computers. They can't make their appointment. We actually reach out to somebody who has contact with them in the community, and we set up a time for them to come and get vaccinated. So we're doing an active outreach for these areas, and other places are doing the same thing.
And that was one of the questions on this list that Charlotte prepared. Another question is, what do you do if you have staff that that are choosing not to be vaccinated, and not because they might have a medical condition where the vaccine is not recommended, but staff that choose not to be vaccinated for?
So that's an evolving scenario. So that's a really good question, because our staff have asked us from the beginning, are you going to make this mandatory? Because we made the flu vaccine mandatory. We were the first hospital to do that. And if you don't get vaccinated, then you can't, because we don't want to transmit.
Oh, of course.
Flu. You're already in the hospital sick. We're not going to let anybody transfer it to anybody there. So while it is not an FDA approved vaccine, but it's under this emergency authorization use, it'd be very difficult to make it a mandatory vaccine. But we will do is at the point that it moves to being approved, I believe the CDC is going to make it a mandatory vaccine, and California Department of Public Health, but we will. And then we will give folks options of not providing direct patient care. That's our biggest concern. So we will move to make some of those changes, but until it's but the other piece of it is those that aren't vaccinated, and again, it's a few of the direct care providers, they're all getting screened when they come in. They all wear their mask. We social distance. We're really strict about that. So that again provides protection.
Okay, yeah. Yeah, I worked at Sharp for years, and anytime someone didn't want to be vaccinated, they wore a mask, but that's kind of redundant. We're all wearing masks. So that I know that there's some questions about the conflict between public health legislation or public health standards and government standards. And is that something you're in a position to comment on?
just in the fact that it creates a lot of conflict for us to be able to do anything. You know, to tell you the truth, I was so excited when as the vaccines were on the horizon and the CDC had that really nice COVID-19 vaccination playbook, and everybody committed that they were going to do this and we were going to follow the rules. And, you know, in reality, an international pandemic at the level we're at, it is difficult to get everybody to do things the same way. But in this country and in other countries, nobody is following it the same way. So it's very difficult to do. And in the end, you know, you've got your federal, you have your state and your county. We need to be compliant with the county because that's where we get our vaccine. That's people who hold us directly responsible. And so, and we work really well with them. So we can be part of that, part of the decision making on where we are. But it is challenging.
Yeah, well, it sounds like you're recommending the CDC website. However, spring break is coming up, and I'm sure there are lots of us who would like to take advantage of it to see our families whom we haven't seen in my case, 16 months, except on Zoom. What are the recommendations for traveling, especially in California, where our different counties, our patchwork of counties, have different standards for what you can and should be doing?
So we really recommend that you don't deviate from all the safety stuff.
Oh.
I mean, do your mask, your social distancing. If you're traveling and you're on a plane, I always say wear a face shield, eye protection. That gives you a little bit more of because viruses enter in through the eyes pretty easily. When if you're traveling and you're staying at a hotel, read up on the hotel. They will tell you what their measures are that they're doing. If they don't have them, you don't want to stay there. And I bring my own bleach wipes. You know, so, it's going to tell me that they clean it, but when I go in, I just do high touch services. And then I keep my hands as clean as possible. I think we're at a point where you can travel, you can visit, but don't forget, you just still need to continue to do those things. And you want you want to make sure people are not symptomatic where you're going, that you really ask that they report any kind of, if they're sick, then to let you know and stay away. Yeah.
Even though you're vaccinated, it's highly recommended that you don't go, right? Because I certainly don't want to subject my grandchildren to having to be quarantined because I've chosen to come up from a high-risk area in San Diego. And you've already answered the question about how you're reaching all the people that don't have access to computers. I know when most of us went online to schedule our vaccinations, we had to fill out healthcare status of some kind or other on that, and that wasn't not an easy thing to complete or fill out at all. I think I'm going to stop talking also, let you rest your voice and see if anybody else in the branch has any questions for you.
Pat?
Yeah.
Cindy, I wondered about those that have cancer because they're vulnerable, and I do have it right now. And luckily, I got Moderna. But I'm wondering about the dose. And I had read that if you just get the dose, that's not, you still need that second dose. But what about those that are, say Johnson and Johnson, or you only have one shot vaccine?
So you've got a couple of interesting things there. One is that the way the Johnson & Johnson or Janssen did the study, they originally did it for a 2-dose vaccine, but then they were identifying that it was pretty effective after the first dose. Moderna and Pfizer are also very effective after the first dose, but all their research was aimed at a 2-dose series. So that's why they're staying there. At some point, they may change. But I would, being high risk with cancer and immunocompromised possibly, you should get your second dose.
I did.
Good. Yeah, and you should continue to do that. I like I said, all three vaccines are good. I'm very, very confident in Moderna and Pfizer. I know a little bit less about. We have a little bit less experience with Johnson and Johnson, but it appears to be very good. And then the studies are coming out now about how long they're effective, and we'll be getting that information about the single dose, which we would expect to not last as long. But it'll take a couple months to get all that data.
Pat, I have a question.
Joan?
Chris, you said the trials are going on now for 16 and under. So I have a granddaughter that's 15 and a half, 14 and 2. And so when might we expect that they get vaccinated?
So the again, Pfizer's is in their trials right now, and I expect that it'll probably be maybe this summer before they get approval.
Okay.
And I'm not sure exactly what level they'll go to, hopefully to all ages. Moderna starts this month, and I think they'll run a little later than Pfizer will, but I would expect that they would be able to get authorization no later than the end of the summer, but it's going to be a while. We originally didn't think it was going to be until the late fall, but because the vaccines have been been rolling out so well, they went ahead and started the pediatric trials sooner.
So that they are considered a low risk group though, right? When I look at that CDC diagram, because I've been vaccinated, but they have not. So
they are low risk for getting complex disease and hospitalization, because when you hear everything about the adult facilities being overwhelmed, we weren't. We admitted less than 500 kids total, and Sharp could have that on one day in their ICUs. The challenges are there is the syndrome. It's called we call it short is MISC-C, but it's multi-system inflammatory disease in children, and it's something that, and they found that it happens also in adults. So it's 4 to 6 weeks after you've had COVID, and you may have had an asymptomatic case. Nobody knew you were sick. Now you have organ failure in 2 organs, and you get pretty sick. And this starting in December, we started to see a lot of these kids. Our highest hospitalization at the time was these MISC-Cs. And there's long-term organ impact. And so we haven't had any deaths. We've been fortunate. But these are the kids that are staying in the ICU for weeks at a time. So the kids are, for the most part, are low risk because they do well. But there is a portion
bringing him in. Can he get vaccinated? I have a question. Go ahead. Go ahead. I have a question. We have a church member. We're overseeing his care at the moment. He lives in a hotel downtown in a 1-bedroom. And the person who's helping him right now and transporting him is in his late 40s. And he's bringing him in for our church member in for a second shot at Children's next week. But the caregiver has not been vaccinated. Can he get vaccinated at that time?
He's eligible, yes. Informal caregivers of individuals who need assistance that are high risk are eligible. So if, I think some of you have my email. If you email me who he's bringing in and then the person's name and contact information, we'll make an appointment for him.
I have a question. This is Carol Patrick, and it's just out of curiosity. When you mentioned the Janssen being just one shot, one vaccine, it just raised my question of, does that mean that it's a stronger dose, that one vaccine, stronger than, the single Pfizer and Moderna?
Great question. Absolutely great question. So in looking at the studies, when they started, and all the companies did the same thing. They had a low dose, they had a medium dose, they had a high dose. And what they do during the research study is they monitor individuals' both immune response and side effect response to those different levels of doses. And so I think with the Janssen one, what they did was they were also able to see what happened with Pfizer and Moderna, because everybody stayed away from the highest dose because it had much more complications, and went to medium. And so Janssen already had some of that data from the other companies, and were able to have the dose around the same dosage effectiveness level, and just how they, it's a little, again, it's how they did the research project that made it so that they decided to just make it a one dose recommendation. Their efficacy would be a little bit higher with 2 doses.
They need
but
9,000
It'd be exactly
doses,
the same as
and they're
Pfizer
only
and
getting
Moderna.
1,100 to beginning of the week.
Right.
I don't know if that helped answer it, but it's decisions that were made and how they asked to be licensed.
Right.
Yeah.
Well, we'll soon find out, but you gave us some excellent information. Lots of it, of course, we've probably read about, but thank you for your presentation. I'm going to mute myself now. Thanks.
You're welcome.
I have a question, Chris. My grandsons are type 1 diabetics. They're age 8 and almost 15, and they're Rady patients. Are they eligible for the clinical testing?
So your volume came in and out, but it sounded like they were 8 and younger than that. So are they're eligible? They're eligible for the trial when we are going to advertise that, and we'll be sending out to everybody that if you want to sign them up for that, and they will be looking for kids with no chronic medical conditions, some with diabetes, some with heart disease. So they'll be doing all of that. And then once the vaccine is approved, any of the vaccines are approved for kids, then we would be trying to get everybody vaccinated, not just high risk, but everybody. But I think the Pfizer vaccine sign up is closed, so but the Moderna is not open yet. It'll be in the next couple of weeks, but we'll be notifying folks to be able to sign up.
So their parents should be notified?
Yes, there'll be an alert that will come out. Yep.
Okay, great, thank you.
Okay. Well, I have 2 more questions, but they're political and I don't want us to start World War III. So I'm going to eliminate those because I think we all have strong feelings about how this has been handled and perhaps how it could have been and should have been. I guess my only concern is the fact that China probably has the longest experience with this strain of coronavirus. And I don't know, I know all the European countries are doing their level best. The countries that we speak to are doing their level best to share research and to share their medical experiences. And I'm just sorry that the politics of international relations have kept us from benefiting from the longer research of the countries that have been dealing with this longer than we have.
Well, China actually was fairly silent in the beginning, which is what I think everybody's most upset about. But we have an awful lot of information about that now. It took a while to come, and we actually have there's a CDC branch that is living in Wuhan to make sure that they have, and the World Health Organization is there to make sure that they have real information. Because countries can, you only know what they really report. They don't necessarily have to report honestly, but they're keeping a pretty good handle on it. And one of somebody I work with in the CDC actually sent me the Wuhan manual back in January of 2020 of what they'd already experienced and what their recommendations were for prevention of transmission. I mean, it's a 200-page document. Wow. And I got that a year ago, January. straight out of Wuhan.
Straight out of Wuhan. Okay. I guess my final question is, how are our gorillas up at Safari Park doing?
So they're doing well. I think they're all doing well. We do know that, again, what you worry about with viruses, and I said from the beginning, this was coming from a bat.
Yeah.
Every species has their own. Pigs have their own, birds have their own, people have their own. And it's when the virus mutates and then can transmit. And so I think the transmission to the gorillas was a little surprising for folks, but makes a lot of sense. And fortunately, they've done well. Same with, there are a couple of dogs that have been diagnosed with COVID-19. And most of the animals aren't being tested for it, but in some of these cases, and doing well. But that is that transmission, or that how they change. And again, what makes viruses to me so interesting, bacteria learns resistance. So they learn about antibiotics and they learn about household cleaners, and they become resistant, which is different than changing. So the basic core of a bacteria is the same, but they learn how to be resistant to different things. Whereas viruses, man, they just take on a life of their own. So
Obviously.
different. So
Right.
So does that mean we can invite the gorillas over for dinner?
you could. Yeah. One of the things we do is we partner with the zoo because they recently discovered that gorillas have heart disease. And so my echo team that do cardiac echoes go over and they do echoes on the gorillas, and they have such a good time. Some of the gorillas they have to sedate, but other ones, the trainers sit and kind of hold them and talk to them, and then our staff do their echo on them. It's been fascinating. So
I bet. No, I bet.
Pat, we
Yeah.
have a request. Many people, Chris, thank you so much, want your email address. Would
okay.
you give that to us, please?
I just put it in the chat for everybody.
Oh,
Yep. And I'll send this presentation if you'd like that.
Yes.
And,
yeah,
and I am also happy to share our link to our town halls, that if you're not doing anything Thursdays from 12 to 1:30, you're more than welcome to join and listen. We talk about anything new, and you also would have access to the old ones. So if you really want to learn a lot about COVID. So
This was so informative. Thank you. Thank you, Chris. I thought I was keeping up with, I'm reading all the articles in the paper and online, and you just were so enlightening. So thank you for making
Yes.
time.
Thank you very
you're
much.
welcome. I've enjoyed this. So
thank you,
thank you.
Chris, so much.
All
And
right.